In this video, we would like to highlight an incidental diagnosis of an unusual strabismus using the pediatric perimeter device. The pediatric perimeter consists of a hemispherical dome with light-emitting diode that are controlled through a computer using a custom-built software. Both static and kinetic stimuli can be shown in this device. Static stimuli include LEDs displayed in one of the four quadrants or one of the cardinal meridians. The kinetic stimulus consists of a single LED lighting up sequentially from the periphery to the center in each of the meridians. The infrared camera mounted at the apex of the dome allows the examiner to watch the real-time video on the graphical user interface. Infant's response to a stimulus can be recorded by a button press by the examiner. Infant's response is detected by observing the gauge, that is eye or head position. In this video, we present a case of a 4-month-old boy accompanied by his mother to participate in a larger study to test visual fields. The mother complained of the infant having a droopy eyelid in the left eye since birth. The infant was placed in a supine position on the mattress on the pediatric perimeter dome so that his face was focused by the infrared camera. The infant's eye and head position were captured on the graphical user interface. On the video screen, the image is laterally inverse such that the infant's left side faces the examiner's left side and vice versa. The fixation light of the pediatric perimeter was turned on and the room light was turned off. Grossly right upper eyelid retraction with ptosis in the left eye was noticed during the testing of the infant. No anisocoria was observed. Upon presentation of the static targets in the fourth quadrant of the dome, it was observed that the infant gazed to the left lower, right lower, and right upper quadrant, and consistently missed the left upper quadrant target. Targets were also missed when kinetic targets were presented in the superior portion of the dome and not in the inferior portion of the dome. The examiner also observed a change in the palpable fissure height of the left eye with jaw opening or when infant hand was inside his mouth. The eyelid movement was seesaw in nature. The infant was referred to a pediatric ophthalmologist in a tertiary eye care center to correlate the video findings clinically. The Taylor visual acuity of the infant was 2.40 cycles per degree in both eyes and equally prefers either eye for fixation with no significant refractive error. On examination in the clinic, the infant was noted to have left eye mild ptosis with Marcus gun jaw winking phenomena and hypotropia. The motility assessment was difficult owing to poor cooperation of the infant in the clinic. There was resistance to occlusion of either eye. There was no pathology observed in the posterior segment with dilated fundus examination. The pediatric perimeter video recordings were reviewed, and as the infant consistently missed the target in the superior part of the visual field in the left eye with limitation of elevation along with Marcus gun jaw winking phenomena, an ocular motility disorder of monocular elevation deficiency was made. At the subsequent visit after 3 months, the pediatric perimeter recordings showed full extraocular motility in the left eye, and hence the diagnosis was changed only to congenital ptosis with Marcus jaw winking phenomena. The most likely explanation for missing the target in the left upper quadrant on the first visit is because the left upper quadrant belongs to the left eye's superior temporal visual field and right eye's superior nasal visual field. Because the left eye had ptosis, the superior temporal visual field was obstructed, and in the right eye, the stimulus extent of the presented target was greater than the 4-month-old infant's usual superior nasal visual field extent. Pediatric eye examination is challenging because of lack of cooperation and shorter attention span in infants. The presence of congenital ptosis in younger infants might predispose as superior visual field defect and could also masquerade as a limitation in elevation. This video highlights the use of pediatric perimeter device for unraveling the mystery of congenital ptosis and monocular elevation deficit in an infant, which is challenging in a routine clinic.